October 1942. Western Desert, Egypt. The British Field Hospital, a collection of sand-coloured tents 30 kilometres behind Allied lines, bustled with the wounded from El Alamein. Oberstabsarzt Klaus Werner, captured 2 days earlier when Panzer Army Africa's medical unit was overrun, stood rigid as the British medical officer delivered words that violated every principle of warfare the German doctor understood. "I'm asking you to operate on 3 RAF pilots. They need immediate thoracic surgery, and frankly, you're more experienced than any surgeon we have available." Werner stared at the British captain, searching for signs of trickery. Nazi briefings had prepared him for interrogation, psychological manipulation, even threats, but not for a request that treated him as a colleague rather than an enemy. The British officer waited, his bloodshot eyes betraying exhaustion after 72 hours without proper sleep. Behind Werner stood 4 other captured German medical officers, equally stunned. 5 doctors among the 267 German medical personnel captured during the recent offensive. Wehrmacht regulations strictly forbade treating enemy wounded while German casualties awaited care. Yet here stood a British officer, offering not coercion but professional respect. The British captain gestured toward a nearby surgical tent. "I understand your reluctance, Herr Doctor, but these men will die without immediate intervention." This single moment in the North African campaign would initiate a medical collaboration that defied military logic, one that would eventually involve 1,241 German medical personnel working alongside British doctors across 27 Allied facilities. The statistics, documented later by the International Red Cross, reveal an unprecedented experiment born not of policy, but of battlefield necessity. Werner had graduated from Heidelberg in 1934, completing his residency as National Socialism transformed German medicine. His training emphasized that medicine served the folk, not humanity in general. For 8 years, professional journals had published articles explaining the biological inferiority of Germany's enemies. Now, in this dusty field hospital, those ideological certainties collided with medical reality. The German doctors had expected harsh treatment upon capture. Propaganda films had shown British brutality toward prisoners. Goebbels' broadcasts described Allied medical facilities as primitive compared to Germany's efficient field hospitals. Werner's capture kit contained materials warning that requests for medical cooperation were merely psychological warfare, designed to extract information. Instead, Werner encountered a medical facility operating at 143% of designed capacity. The hospital, intended for 200 patients, now held 286, with 47 critical cases requiring immediate surgery. British medical supplies, while different from German equivalents, appeared abundant. Blood plasma, sulfonamides, and morphine sat in quantities that German medical units hadn't seen since the campaign began. "Your expertise in thoracic trauma from your work in Warsaw is particularly relevant," the British captain continued, consulting a folder containing Werner's service record. This detail disoriented the German doctor further. They knew his specific medical background. The British officer, introducing himself as Captain Jonathan Harrington, RAMC, led Werner through the pre-operative area. Wounded British, Australian and New Zealand soldiers watched the German doctor pass, some with visible concern. Werner noticed no restraints on his movement, no guard with raised rifle tracking his steps, just medical personnel focused on saving lives. The thoracic cases waiting for surgery presented classical penetrating wounds from aircraft shrapnel, exactly the injuries Werner had specialized in treating during the Warsaw campaign and later in North Africa. The first patient, a 23-year-old RAF pilot with shrapnel lodged dangerously close to his aorta, required precision Werner had practiced hundreds of times. Captain Harrington explained the situation matter-of-factly. "Our thoracic surgeon was killed 3 days ago. The replacement is still 48 hours away. These men won't survive that long." The Geneva Convention permitted medical officers to treat wounded prisoners of their own nationality. No provision explicitly addressed enemy doctors treating Allied wounded. This grey area, neither forbidden nor sanctioned, created the ethical tension gripping Werner. For 8 years, Werner had absorbed the message that enemy lives held less value than German ones. Yet his Hippocratic training, predating National Socialism, had emphasized that suffering transcended national boundaries. The conflict between these competing ethics manifested physically. His hands trembled slightly as he examined the X-rays Harrington provided. "These films are remarkably clear," Werner commented, professional interest momentarily superseding ideological hesitation. The British mobile X-ray equipment surpassed what his unit had been using. The moment stretched into painful silence. The other German doctors watched Werner's reaction, their own responses contingent on his decision. Hauptmann Ernst Schäfer, an anesthesiologist from Munich, stepped forward. "If Herr Oberstabsarzt Werner operates, I will assist with anesthesia." What began as an emergency request would evolve into the war's most unusual medical collaboration. By war's end, over 17,400 Allied personnel would receive treatment from German medical officers who, like Werner, made a decision that placed professional ethics above national loyalty. Documentation from both German and British military archives confirms that this unplanned cooperation achieved survival rates 24% higher than standard field hospitals on either side. Werner looked again at the wounded pilot. The man's laboured breathing marked a countdown that transcended politics. Professional instinct, trained through thousands of operations, recognized the specific pattern of respiratory distress that preceded cardiovascular collapse. "I will need my instruments," Werner finally said. "They were in my medical bag when I was captured." The collaboration that would undermine years of indoctrination began with this simple, reluctant agreement. One doctor recognizing another's expertise, and a patient whose need outweighed national boundaries. Werner's first operation on the RAF pilot lasted 4 hours and 17 minutes. His German surgical training emphasized precision and efficiency, qualities drilled into every medical officer of the Wehrmacht. Standing across from him, British surgical nurse Lieutenant Sarah Blackwood tracked his movements with professional scrutiny, ready to intervene if the enemy doctor attempted anything untoward. By the second hour, her vigilance had transformed into collaborative rhythm, anticipating instruments before Werner requested them. German military physicians received standardized training at 7 medical academies established after 1935. These institutions emphasized not only clinical skills but ideological preparation. Lectures on military medical ethics in the National Socialist state were mandatory, explaining how conservation of resources should prioritize those most valuable to the Reich. Treating enemy wounded represented misallocation of German expertise. Yet here in the desert, surrounded by British medical personnel, the 267 captured German doctors found themselves confronting a paradox. Their skills were being valued precisely because they were German. "Your approach to the intercostal space is different from our technique," observed Major William Thornton, the British medical officer who assisted Werner during that first surgery. "More conservative with tissue." The German technique for accessing thoracic injuries had been refined during the Spanish Civil War, where Luftwaffe medical units gained experience treating shrapnel wounds. British approaches followed different protocols developed in tropical medicine settings. The Wehrmacht maintained 43 specialized field surgical units by 1942, with standardized techniques taught at the Military Medical Academy in Berlin. This technical expertise, developed to protect German soldiers, was now preserving enemy lives. Within 72 hours of Werner's first operation, 17 additional German doctors were performing procedures on Allied wounded. The British Medical Command, facing a shortage of 115 surgical specialists across the North African theatre, recognized the pragmatic advantage. Each captured medical officer represented years of specialized training that could not be quickly replaced on either side. "When they first asked me to treat British soldiers, I expected a propaganda photographer to appear," recalled Hauptmann Friedrich Müller in post-war interviews. "I thought they would use images of us treating their wounded to suggest we had changed sides." No such photographers materialized. The collaboration remained a practical arrangement born of necessity, not a propaganda exercise. Across the Western Desert Campaign, medical resources told contrasting stories of the two armies. British field hospitals maintained stocks of 24 blood units per 100 beds. German facilities operated with 9.7 units by late 1942 as supply lines stretched across North Africa. British antibacterial sulfonamides remained available at 87% of recommended inventory levels. German supplies had fallen to 42%. This disparity created cognitive dissonance for German physicians who had been told of British material shortages. By November 1942, the initial emergency arrangement had evolved into systematic cooperation. German specialists were distributed among Allied medical installations based on expertise. Neurologists, orthopedic surgeons, infectious disease specialists, each allocated where skills addressed specific needs. At the 16th British Field Hospital near Alexandria, 7 German doctors worked alongside 9 British counterparts, treating both Allied and Axis wounded. Werner, initially the most reluctant collaborator, found himself appointed informal coordinator for German medical personnel at 3 British installations. His daily rounds included 64 beds containing wounded British, Australian, New Zealand, South African, Indian, and German patients. The strict segregation he expected never materialized. Triage decisions were made on medical priority, not nationality. The ethical framework governing these interactions remained unwritten. The Geneva Convention specified that captured medical personnel retained their status and could not be considered prisoners of war in the conventional sense. They could be retained to treat prisoners from their own forces, but were entitled to repatriation when no longer needed. No provision addressed their treatment of enemy wounded. This legal ambiguity created space for a pragmatism that transcended written protocols. I found myself consulting with Major Harrington on treatment approaches for chest wounds, Werner noted in letters that were later preserved in British military archives. His experience with tropical infections complemented my background in trauma. We developed hybrid approaches neither of us had considered before. These letters, censored but retained, document the intellectual exchange that paralleled medical collaboration. German doctors recognized strengths in British approaches to wound management and infection control. British physicians adopted German techniques for vascular surgery and pain management. By December 1942, informal training sessions occurred during quiet periods, with doctors from both armies demonstrating techniques to mixed audiences of medical personnel. Captain Thomas Wellington, RAMC, documented this unexpected development in his official reports. German thoracic specialists have introduced modifications to our standard procedures for hemothorax evacuation, resulting in 28% reduction in post-operative complications. Their techniques for minimizing tissue trauma during thoracotomy are being adopted by our surgical teams. The professional respect underlying these exchanges created tension with national loyalty. German doctors took professional pride in successful outcomes, even when the patients were enemy combatants. British medical officers found themselves defending German colleagues from occasional hostility from newly arrived personnel or recovered patients. This solidarity emerged not from political alignment, but from shared professional identity. For Werner, the watershed moment came in December 1942, when he successfully operated on a critically wounded British officer while a German pilot recuperated in the adjacent bed. Both thanked him with identical phrases. "You saved my life, Doctor." In that moment, separated from the ideologies that placed these men on opposite sides, Werner confronted the essential humanity that transcended the artificial boundaries of conflict. The doctor had begun to replace the soldier. By January 1943, the improvised cooperation had evolved into organized medical teams. British field hospitals now formally integrated German medical personnel into their staffing structures. At the 31st General Hospital outside Cairo, 16 German physicians worked alongside 23 British doctors in mixed specialty units. Surgery teams typically comprised 1 British and 1 German surgeon, sharing responsibility for pre-operative assessment and procedural decisions. British military records document 172 such mixed medical teams operating across North Africa by mid-1943. The integration extended beyond physician cooperation. German nurses, captured alongside medical units, found themselves working with British counterparts. Oberschwester Maria Hoffmann, senior nurse from a Panzer Division medical company, supervised a 30-bed ward, where 4 German and 5 British nurses provided care for wounded from both armies. Language barriers gradually dissolved as medical terminology created a shared vocabulary transcending national divisions. "We developed hand signals first," Hoffmann later recalled in Red Cross debriefings. "Then medical terms became our common language. Hemorrhage and infection sound similar in both languages. Within weeks we had created our own hybrid vocabulary." This linguistic integration paralleled a more significant merger of medical approaches. The German military medical system emphasized standardized protocols based on experiences from the Eastern Front and North Africa. British colonial medicine contributed tropical disease expertise and improvisation skills developed across diverse environments. The desert environment itself imposed unique challenges that neither system had fully solved independently. Sand complicated everything. Fine desert particles infiltrated wounds, creating infection risks that standard treatments struggled to address. German doctors had developed specialized irrigation techniques using solutions of hydrogen peroxide and saline. British medical units contributed advanced sulfonamide compounds unavailable to German forces after supply lines stretched across the Mediterranean. The combined approach achieved infection reduction rates of 64% compared to the previous standard treatments. Dehydration presented another desert-specific challenge. German medical units utilized a systematic approach to fluid replacement based on patient weight and blood pressure measurements taken at 15-minute intervals. British units contributed electrolyte solutions developed for tropical deployment. The collaborative protocol that emerged reduced kidney failure rates by 37% compared to previous methods. Beyond technical improvements, the mixed medical teams discovered unexpected efficiency gains. German organizational systems streamlined patient processing, while British flexibility adapted to rapidly changing conditions. Supply management integrated German precision with British improvisational skills. The 16th Field Surgical Unit, with 5 German and 7 British staff, achieved a record of processing 143 patients in a 24-hour period during the aftermath of Operation Supercharge. Physical layouts of treatment facilities evolved to reflect this integration. Traditional separation of enemy wounded gave way to organization by medical condition rather than nationality. Neurological cases, regardless of uniform, were grouped together. Orthopedic wards contained both German and Allied patients. This reorganization improved specialist efficiency, as physicians could treat similar conditions sequentially, applying lessons from each case to the next. Medical equipment itself became shared technology. German surgical instruments, renowned for precision engineering, were integrated into British operating theatres. British mobile X-ray units, more advanced than German equivalents, were operated by mixed technical teams. German microscopes paired with British laboratory supplies. Even pharmaceutical approaches merged, with German analgesic protocols combining with British antibiotic regimens. Documentation systems reflected this integration. Patient charts incorporated elements from both military medical traditions. German precision in tracking vital signs complemented British narrative assessment approaches. The resulting hybrid records provided more comprehensive patient monitoring than either system alone had achieved. By spring 1943, this collaboration had produced measurable results. Survival rates for complex procedures increased significantly. Thoracic surgeries performed by mixed teams showed 76.3% survival rates compared to 62.8% in single nationality teams. Abdominal trauma survival improved from 47% to 58.4%. These statistics, meticulously documented in British military medical journals, demonstrated the tangible benefits of cooperation. Knowledge transfer became increasingly formalized. Weekly case conferences brought together medical personnel from both armies to discuss challenging cases and novel approaches. German expertise in extremity trauma from the Russian winter campaign proved valuable for frostbite cases from high-altitude flight crews. British tropical medicine protocols helped address dysentery outbreaks affecting both armies. "We found ourselves teaching each other," Werner noted in personal correspondence preserved in military archives. Captain Harrington demonstrated techniques for tropical ulcer management I'd never encountered. The next day I shared our approach to managing trauma-induced neurological compression. This professional exchange extended beyond immediate treatment concerns. German and British doctors began discussing fundamental approaches to military medicine. German emphasis on returning soldiers to duty confronted British focus on long-term patient outcomes. These philosophical differences sparked debates that influenced both systems. The desert environment itself forced innovation. Water conservation techniques developed by German desert veterans combined with British solar sterilization methods to create new protocols for resource-limited settings. Dust management systems integrated German engineering with British colonial adaptations. Neither system alone had solved these challenges effectively. Major William Thornton documented this transformation in his official reports. The integration of German medical personnel has evolved from emergency expediency to systematic advantage. Their technical precision complements our adaptability. Both medical services are evolving through this unexpected collaboration. As the North African campaign concluded, this medical integration faced a new challenge. What had developed as a pragmatic response to battlefield necessity had created relationships and systems that transcended the immediate crisis. The question emerging by mid-1943 was whether this medical collaboration represented merely a practical arrangement or something more fundamental, a recognition of shared humanity that war could not entirely erase. Flight Lieutenant James Harrington regained consciousness after his third surgery, performed by Oberstabsarzt Werner and a British surgeon working in tandem. His Spitfire had been shot down during a reconnaissance mission, leaving him with extensive shrapnel wounds and a punctured lung. When told a German doctor had led the procedure that saved his life, Harrington initially refused to believe it. By his fourth day of recovery, he found himself discussing aircraft design with the same German physician who had extracted 27 metal fragments from his chest. "He knew more about the Spitfire's cockpit configuration than I expected," Harrington noted in a letter home that was preserved in RAF archives. He explained that understanding where pilots sit helped him anticipate injury patterns. It was disconcerting to realize he had used this knowledge to treat both sides. This pattern repeated across Allied medical facilities as wounded pilots and infantrymen confronted the reality that enemy doctors had preserved their lives. By mid-1943, German medical personnel had performed 7,123 surgical procedures on Allied personnel, with success rates matching or exceeding standard outcomes. The British 8th Army Medical Corps documented a 91.4% survival rate for patients receiving emergency surgery from mixed medical teams, a 7% improvement over previous statistics. Captain Richard Montgomery, severely wounded at Tobruk, recorded his experience. "I expected to die when they told me only a German surgeon was available. Now I owe my life to a man I was trained to kill." How do I reconcile that? This reconciliation challenge extended to both sides. For Allied patients, gratitude conflicted with ingrained suspicion. For German medical personnel, professional satisfaction in successful outcomes competed with awareness they were strengthening an enemy force. Yet daily proximity gradually transformed perceptions in ways propaganda could not counter. The transformation occurred through specific cases that forced recognition of shared humanity. When a British bomber crew and their German pursuers arrived simultaneously at the 31st Field Hospital, both critically injured after their aircraft collided, German and British medical teams worked side by side, moving between enemy casualties based on medical priority rather than nationality. 3 German and 4 British airmen survived because of this integrated care. Their adjacent recovery beds created a microcosm where national divisions temporarily dissolved. Werner documented a particularly significant case in his personal journal. "Today I performed emergency surgery on a British communications officer who carried operational maps. The intelligence value would have been considerable. 2 years ago, I might have considered delay to allow document seizure. Today, such a thought never occurred to me or my British colleagues. The patient's survival was our only consideration." This moral clarity, placing medical ethics above military advantage, represented a profound shift. The International Red Cross, monitoring these developments, reported, "German medical personnel increasingly identify with their professional role rather than their military function. This represents a significant departure from initial observations." British military authorities, initially cautious about the arrangement, gradually formalized it through official protocols. Directive 147.3, issued in April 1943, established guidelines for German medical officer integration, standardizing practices that had emerged organically. The document acknowledged, "German specialists have demonstrated professional conduct consistent with highest medical standards. Their continued service benefits Allied medical capabilities." This official recognition facilitated expanded collaboration. German surgical specialists were transferred between facilities based on medical needs rather than security concerns. By summer 1943, specialized treatment centers employed German and British personnel in integrated departments. The Bern Treatment Center in Alexandria, treating aviators from both sides, operated with 7 German and 11 British medical staff, developing advanced protocols through combined expertise. Language barriers, initially requiring translators for complex discussions, gradually dissolved through daily interaction. Medical terminology provided initial common ground, but communication expanded beyond professional necessity. British medical officers who had studied in Germany before the war discovered shared educational experiences with their German counterparts. Scientific interest transcended political divisions. Discussions of medical innovations occasionally involved references to research journals both sides had read before hostilities severed academic connections. Patient reactions evolved as the collaboration became routine. British soldier Thomas Jenkins, wounded at El Alamein, recorded his experience. "At first I watched the German doctor suspiciously. By the 3rd day, I was asking his opinion about my recovery timeline. Somehow he became just my doctor, rather than the German." This normalization extended through the ward systems. British and German nurses developed integrated patient care approaches, combining elements from both training traditions. German precision in wound management complemented British emphasis on patient comfort. The resulting hybrid approach achieved infection rate reductions documented in nursing reports submitted to military authorities. Administrative integration followed clinical collaboration. German medical officers gradually assumed departmental responsibilities alongside British counterparts. At the combined medical facility in Cairo, Hauptmann Ernst Schäfer co-directed the thoracic surgery department with Major William Thornton, jointly supervising a staff of 23, including personnel from both armies. Their department achieved the lowest mortality rates for thoracic trauma in the North African theatre. Operational security concerns that initially restricted German personnel gradually relaxed as trust developed. German doctors received access to the same medical intelligence as their British counterparts, information about incoming casualties, outbreak patterns, and resource availability. This information sharing prioritized patient outcomes over traditional security protocols. British military authorities documented this evolution in classified assessments. German medical officers have demonstrated commitment to professional ethics that transcends political alignment. Their integration has improved treatment outcomes and resource utilization efficiency. Recommendation: expand program to additional facilities. The transformation extended beyond professional cooperation to personal understanding. Werner's journal entry from September 1943 reflected this shift. "Today marks 1 year since my capture. I expected to serve the Reich by treating our wounded as a prisoner. Instead, I find myself part of a medical community where nationality has become secondary to our shared commitment to preserving life. I have not abandoned Germany, but I have discovered that medical ethics transcend borders in ways I never anticipated. This realization, that professional identity could supersede national allegiance without constituting betrayal, represented the most profound aspect of the collaboration. The German doctors remained loyal to their country while discovering that humanity extended beyond national boundaries. This paradox, seemingly contradictory in military terms, made perfect sense within the context of medical ethics. The integration of German medical expertise expanded beyond surgical theatres into broader aspects of military medicine. At Camp Willoughby near Cairo, a transition hospital established in late 1943, German physicians introduced preventative health protocols developed for desert conditions. These measures, refined through the Africa Corps experience, reduced heat-related illnesses by 63% compared to previous British approaches. When implemented across 12 Allied medical facilities, these German techniques prevented an estimated 4,735 cases of severe dehydration and associated complications during the summer months of 1944. The German system for managing water consumption and salt replacement proved remarkably effective, noted Colonel James Weatherby, Chief Medical Officer for British forces in Egypt. Their regimented approach, initially dismissed as typically German over-organisation, demonstrated clear advantages in preventing heat casualties. British military authorities, recognising these benefits, formally adopted modified versions of German protocols through Medical Directive 157, issued in February 1944. The document acknowledged the German contribution directly. Preventative measures developed by German medical personnel have significantly reduced non-combat casualties and are hereby implemented as standard practice. This official recognition of German medical contributions extended to administrative systems. German approaches to medical supply management, emphasizing precise inventory control and standardized resupply calculations, were integrated into British logistical operations. The resulting hybrid system reduced waste by 24%, while improving critical supply availability by 17%. According to quartermaster records from mid-1944, Werner, now serving as co-director of thoracic surgery at the 42nd General Hospital, participated in a formal British medical conference in March 1944. His presentation on penetrating chest wounds was attended by 47 Allied medical officers who implemented his techniques across multiple treatment facilities. This professional recognition would have been unimaginable 18 months earlier when he stood as a captured enemy officer. The relationships formed through medical collaboration created unexpected channels of influence. When typhus threatened to spread through POW facilities in late 1943, German doctors recommended preventative measures based on experiences from the Eastern Front. British authorities implemented these recommendations, preventing a potential epidemic. Medical records document only 147 typhus cases among 28,500 at-risk prisoners, a fraction of projected infections without intervention. German psychiatric approaches to combat stress found particular resonance with British medical authorities. Hauptmann Karl Brenner, a neuropsychiatrist captured at Tobruk, introduced treatment protocols developed during the Blitzkrieg campaigns. These techniques, emphasizing rapid intervention near the front lines, reduced evacuation rates for psychological casualties by 41% when implemented by British medical units. By mid-1944, 6 treatment centres operated with integrated psychiatric teams using combined methodologies. The German approach to what they term combat fatigue differs significantly from our previous model, reported Major Elizabeth Harrison, psychiatric consultant to Allied forces. Their emphasis on proximity, immediacy, and expectation of recovery has demonstrated marked improvements in return-to-duty rates. This professional respect gradually influenced broader camp dynamics. German medical officers, initially segregated during non-duty hours, were increasingly integrated into general officer facilities. At El Shat Military Hospital, German doctors shared dining facilities and recreation areas with British counterparts, a de facto recognition of professional equality that contradicted traditional POW hierarchies. Cultural exchanges developed naturally through this proximity. German doctors introduced their British colleagues to chess tournaments organised with the precision expected of German officers. British medical personnel reciprocated with cricket matches that thoroughly confused their German counterparts. These social interactions, documented in personal journals and letters, created relationships transcending professional necessity. Educational exchange formalized these developing connections. By early 1944, regular medical lectures featured speakers from both armies. German specialists shared techniques developed through European campaign experiences, while British experts presented colonial medicine approaches. These sessions, initially focused on immediate treatment concerns, expanded to include fundamental medical research and post-war implications. Medical records document 267 formal presentations by German physicians to Allied medical audiences between January 1944 and May 1945. These sessions covered specialized surgical techniques, tropical disease management, and preventative medicine. Attendance records show consistent participation by senior Allied medical officers, indicating institutional recognition of German expertise. This collaboration drew attention from international observers. The International Red Cross dispatched Dr. Henry Junod to evaluate the program in April 1944. His report concluded, "The integration of German medical personnel into Allied facilities represents an unprecedented humanitarian achievement. Both patient outcomes and professional standards have benefited significantly from this arrangement." Swedish neutral observers echoed this assessment. Dr. Gustav Lindström, representing the Swedish Red Cross, reported, "The medical collaboration transcends traditional prisoner treatment. German doctors function as respected colleagues rather than captives, creating a model that prioritizes humanitarian concerns over political divisions." This international validation prompted further expansion of the program. By late 1944, German medical expertise was being systematically distributed throughout the Mediterranean theatre. Specialists were assigned based on medical need rather than security considerations, creating a network of German expertise embedded within the Allied medical system. Statistical analysis confirmed the program's impact. Treatment facilities employing integrated medical teams reported mortality rates 17% lower than comparable units without German personnel. Infection complications decreased by 29%, while return-to-duty rates improved by 24%. These outcomes, documented through standard military medical reporting systems, provided quantitative evidence supporting qualitative observations. The Allied advance through Europe created new challenges for this established collaboration. As German territory came under Allied control, medical facilities containing both German and Allied wounded required management. The model developed in North Africa provided a template, with captured German medical personnel integrated into treatment teams rather than replaced. By early 1945, 23 former German military hospitals operated under joint administration. Werner's colleague, Hauptmann Friedrich Müller, was among the first German doctors to witness this full-circle transformation. Captured in North Africa in 1942, transferred to European operations in 1944, he found himself supervising a ward in Frankfurt containing wounded from both armies. The journey from enemy doctor to trusted colleague occurred so gradually that its magnitude only became apparent when I found myself treating German civilians and Allied personnel with exactly the same concern, he later recalled. This evolution represented more than practical adaptation. It demonstrated how professional identity could transcend national boundaries even during active conflict. The German doctors had not abandoned their national identity, but they had discovered a professional ethics that existed independent of political allegiance. As the European war approached its conclusion, The medical collaboration established in the desert had evolved from emergency expediency to systematic integration, creating a model that would influence post-war international medicine in ways none of its participants could have anticipated in that first moment of stunned disbelief in the Western Desert. May 1945 brought the war's end and confronted the integrated medical teams with separation. Oberstabsarzt Werner, who had performed 341 thoracic surgeries on Allied personnel over 31 months of captivity, received repatriation orders with mixed emotions. His British colleagues organised a formal dinner the night before his departure, an honour unprecedented for enemy personnel. The hospital commander presented Werner with a leather-bound volume containing signatures of 237 patients whose lives he had saved, including 182 Allied servicemen. "You came to us as an enemy and leave as a colleague," stated the citation accompanying this unusual gift. Your commitment to medical ethics transcended the divisions of conflict. Werner returned to a Germany unrecognizable from the nation he had left. Frankfurt, where he had studied medicine, lay in ruins. The hospital where he had completed his residency no longer existed. Yet amidst this destruction, he carried experiences that would influence the rebuilding of German medicine. Within 6 months of repatriation, Werner received an invitation to lecture at the Royal College of Surgeons in London, the first German physician to receive such recognition after the war. The medical collaboration that began with stunning disbelief in the Western Desert ultimately involved 1,741 German doctors and 345 German medical personnel working alongside Allied counterparts. Together, they treated approximately 567,000 patients, including 230,400 Allied personnel. Mortality rates in facilities with integrated teams averaged 6.7% compared to 9.3% in conventional military hospitals, a difference representing approximately 14,700 lives saved through this unprecedented cooperation. Beyond these statistics lay individual stories of transformation. Flight Lieutenant Douglas Harrison, whose life Werner saved after his bomber crashed, maintained correspondence with the German doctor for 27 years. Their letters, preserved in the Imperial War Museum, document an unlikely friendship forged through medical intervention. When Harrison required follow-up surgery in 1952, he travelled to Frankfurt specifically to have Werner perform the procedure. "The man who saved my life when protocol dictated I was his enemy became the only surgeon I would trust with my future," Harrison explained in a BBC interview in 1967. "Politics divided us temporarily, but medicine created a permanent connection." This personal reconciliation paralleled professional reintegration. By 1948, 16 former German military doctors who had served in integrated medical teams were participating in international medical conferences. Their research papers, documenting techniques developed through wartime collaboration, appeared in The Lancet, the British Medical Journal, and other prestigious publications. The British Medical Association established a formal exchange program with German medical institutions in 1950, with former POW doctors serving as the initial participants. Werner himself became a visiting professor at the University of Edinburgh in 1951, teaching thoracic surgical techniques developed during his captivity. His textbook, Thoracic Trauma Management, published in 1953, acknowledged his British colleagues and became standard reference material in medical schools across Europe. The preface stated, "This work represents knowledge acquired through circumstances none would wish repeated, yet which yielded insights only possible when differing traditions merge through necessity." The medical collaboration influenced institutional development beyond individual careers. When the World Health Organization formed in 1948, its emergency response protocols incorporated lessons from the integrated medical teams. The International Committee of the Red Cross revised its guidelines for medical personnel in armed conflicts, explicitly referencing the Anglo-German collaboration as a model for maintaining medical ethics during warfare. NATO's medical service, established in 1949, adopted integrated training programs that drew directly from this wartime experience. German and British military doctors who had worked together in captivity helped design protocols for multinational medical cooperation. The standardized NATO emergency treatment cards, implemented in 1952, combined elements from both German and British documentation systems developed during their collaboration. Major William Thornton, who had worked alongside Werner from that first stunning request, reflected on the transformation in a 1965 address to the Royal Society of Medicine. "We asked enemy doctors to treat our wounded out of desperate necessity. What developed transcended pragmatism, revealing that medical ethics could survive the most divisive conflict in history. This lesson may prove our most valuable inheritance from those terrible years." The patients who experienced this unusual care offered particularly powerful testimony. Arthur Williams, an RAF navigator treated by German surgeons after being severely burned when his Lancaster was shot down, spoke at the International Congress of War Medicine in Geneva in 1953. "I arrived at that field hospital certain I would die. The German doctor who treated my burns approached me not as an enemy, but as a patient deserving his best skill. This experience fundamentally changed how I understand human capacity for transcending artificial divisions." Statistical analysis conducted for the British Ministry of Health in 1955 documented the long-term impact of techniques developed through this collaboration. Thoracic surgical protocols introduced by German specialists reduced long-term complications by 34% compared to previous approaches. Burn treatment methods developed through combined expertise decreased scarring by 27% and improved functional outcomes by 31%. These improvements, integrated into standard medical practice, continued saving lives decades after the war ended. The most profound legacy emerged through educational lineage. The doctors who experienced this collaboration trained subsequent generations of medical practitioners. Werner taught at Frankfurt University Medical School from 1949 until 1972, instructing over 3,400 German medical students. His British counterpart, Major Thornton, similarly influenced British medical education at King's College London. Both men emphasized that medical ethics transcended political boundaries, a lesson learned through direct experience rather than theoretical instruction. Werner's final public statement before his death in 1984 distilled this legacy. "When that British officer asked me to operate on enemy pilots, I confronted the artificial nature of human conflicts. The wounded man before me was not an abstract enemy, but a patient requiring care my training obligated me to provide." This recognition, that our shared humanity transcends temporary political divisions, represents the essential truth medicine offers a world too often defined by conflict. The German doctors, who were stunned when British soldiers asked them to treat wounded RAF pilots, discovered something beyond medical collaboration. They experienced the transformative power of professional ethics strong enough to withstand the most divisive forces of the 20th century. Their story demonstrates that even amid humanity's darkest moments, the commitment to preserving life can transcend the artificial boundaries that separate us. What began with disbelief in a desert field hospital ultimately revealed that healing represents not merely a technical skill, but a profound commitment to recognizing our essential connection, a legacy that continues in modern international medicine, where physicians still cross borders and political divisions to uphold the fundamental principle Werner and his colleagues discovered: that suffering transcends nationality, and those with the ability to relieve it share an obligation that supersedes the temporary divisions of conflict.